welcome to the Older Vermonters Caucus. Today we have Jill Olson, who's giving us a overview of the grant that the state of Vermont got. So I know her time is limited, so I'm just going to turn it over to her and really appreciate you being here today. Thank you so much.
Thank you. I'm happy to be here. Can you guys still hear me? I just did things and now I can hear you very well.
Absolutely can hear you.
Okay, there we go. Thank you so much. I'm Jill Olson. I am the Medicaid and Health Systems Director for the Agency of Human Services. I sit in the Secretary's office and have broad responsibility for healthcare reform and for the Medicaid program. And so this falls under my healthcare reform duties. Many people probably read about this program in the newspaper. Vermont was, back at the end of December, we were awarded $195 million for the first year of the grant by the federal government to transform our rural healthcare system. That is the purpose of the funding. It was a $200 million opportunity. So we applied for $200 million worth of funding and we received $195 million. All 50 states applied. All 50 states applied for 200 million. Some got less than 200, some got more. We ended up kind of in the middle. And what I've been saying as I talk about this is that the notice of funding opportunity from the Centers for Medicare and Medicaid Services, which you'll hear me call CMS from here on out, had some criteria for scoring that we couldn't change. So there were policies that were preferred in the notice of funding opportunity that were different than the policies that Vermont has enacted in the healthcare space. And then there were also measures of how rural the state was. And while most of us consider Vermont a rural place, we actually didn't score as high as you might expect based on the kinds of measures that were used. So things like the number of square miles in the state was one of the criteria. So on a square miles perspective, we're not that rural. And so we knew we weren't going to score as highly on those two sets of factors, policy and rurality. And what that means is the size of our award is really a reflection of the fact that the application was strong, because all we had to go on was the strength of the of what we submitted as potential projects. So we have a lot of information. I'm not going to try to go through every project because I have done so in numerous settings, and I can tell you it takes a long time. And there's in the upwards of 30 different projects. But broadly speaking, what we're trying to do with these funds is strengthen our healthcare workforce, use technology in new ways especially to provide care in rural communities. We are trying to support our primary care system and our communication between primary care and specialists. And we're trying to do some other sort of innovative transformation work to change how care is delivered. So things like using the EMS, emergency medical services workforce, in a new way to provide care actually in people's homes, because EMS is actually a workforce that sometimes has some time available and has the potential to do some of that care. Or other examples are where we are looking to build some new capacity within skilled nursing facilities for dialysis and for events. And those are two areas of really high need that some people have, and we have very little capacity. We have no dialysis capacity in nursing homes, so people have to travel to dialysis centers. And we have, I think, only one facility that has event. And so having more capacity for that really high acuity care in our long-term care system is something that we suggested, and we were awarded funding for that. So we're really trying to make, we're thinking about these dollars as essentially one-time funding. So these are dollars that we're going to use to invest in new programs. In some cases, we may be bridging some gaps with programs that have run out of funding but might be funded in another year under a future healthcare reform model with the feds. And sometimes we're using it as a bridge, but it's a whole series of different kinds of initiatives all aimed at rural healthcare. If you're really interested and you really want to see all of our projects, they are on our website. So we have a rural health transformation website, dedicated website, and it has the program narrative as we submitted it to CMS. But what I find most people are finding most interesting is there is a list of projects with a short description. And so you can really like get a better flavor for like what are all the projects that we're currently working on funding. I have a few more things to say about just sort of timing and process, but I'm going to pause there, Dan, just to see if there's any questions before I keep going. Should I take questions? You take questions?
Yeah, sure. If you've got time, that would be lovely.
Okay, so we just pause for a second.
Yeah, one of the things that I'm interested in is the investments in workforce development, because we've heard about the need, especially in our care providers, whether nursing homes or res care. So can these funds be used to, recruit and develop and train a workforce?
Yes, we believe they can. So we have funding for in the Rural Health Transformation Program. We have funding for what I would call several different ways of supporting the workforce that's already working. So helping people with licensing fees or the other kinds of just the kinds of fees you sometimes need to pay in order to remain a licensed provider. We have funding for clinical, we call them residencies, which is essentially taking people who are maybe new, who have graduated from school. So they are licensed and sort of ready to go, but inexperienced. And there's a lot of settings that are just challenging, and we're, learning how to be a new healthcare worker actually requires a fair amount of oversight from somebody who's more experienced. And so particularly like you think about areas like home health, where, it used to be that a home health agency would say you'd never hire a new nurse right out of school for home health. It's just requires too much experience. Home health nurses go down long dirt roads all by themselves and provide care without any supervision in the moment. And so that's an area where a residency program, home health agencies have found to be really useful, because it's pairing that new nurse with somebody who's more experienced to really, bring them up to a place where they're more comfortable. So we have, and then we also have some, we call it conditional tuition assistance. So this is one of the requirements of the notice of funding opportunity, is that if we provide tuition assistance, it has to come with a 5-year service commitment to Vermont. So we have a project that will do that, and for many levels of care. So nurses, but also LNA, so RNs, but LNAs, medical techs, radiology techs. So lots of different kinds of services.
That's great news. Any questions in the room?
One.
Okay. Mary Alice, go ahead.
Oh, I just wanted to ask if H433 goes through and we start with universal primary care. You said there's something in there about changing primary care. Could that be used to help provide primary care without any copays or deductibles to everybody?
No. The short answer is no.
Why not?
The funding is not allowed to be used in that way. It's just not an allowable use of the funds. So we can use the funds to provide, so we can't use the funds for services that are otherwise billable, is one of the restrictions on the funding. We can't use the funding for premiums, co-pays, any kind of out-of-pocket costs for individuals. It's just simply not an allowable use of the dollars. So what I always say about this program is that it's not our healthcare reform plan. It's a tool that we're using to support healthcare reform. And so we're using it in the ways that we want to use it, that support the work we're trying to do, but it doesn't do everything. So we're using the dollars as we can use them. So what we can do is provide additional payments to primary care for things like expanded hours and adhering to certain quality standards and providing more care coordination. We can do that. We can provide funding for the Blueprint community health teams, which are teams of individuals who have other kinds of skills beyond physicians to, wrap around and support primary care, integrate mental health into primary care. So there are some really interesting and important things that we can do, but we can't spend it in all the ways that you might imagine wanting to spend dollars.
Yeah, we have a question in the room here.
Yeah, thank you. It's exciting work. I'm wondering how it will impact the finances of our hospital system. We're hearing a lot about precarious state of our hospitals, and I was wondering if there's any overlap or if there's any influence that this money will have on that system.
Yeah, so I would say yes, but not what we can't use it for. Again, limited use of funds. We can't use it for simply for sustainability. So we can't use it. So we have, say, a provider stabilization program in Vermont where that's available to many kinds of providers when they're in serious financial difficulty, and we provide them funding to develop a sustainability plan and hopefully be able to continue to provide services. We can't use it for that. We can, however, if say a hospital has an innovative idea for how they might transform a service, maybe they bring in a new partner, maybe they take a service that they're providing as part of the hospital system and they actually have a partner that's external to the hospital, like a medical practice where they want to do a transition. Some of that we might be able to support. So that's we have one of the lines in the model is it's transformation grants, and it's really creative ways to change our system. Some of the expenses are allowable and some are not. This is actually a really good time for me to say something I haven't said yet, which is that this is not a grant. It's a cooperative agreement. And what that means is a very high degree of oversight from CMS. So they will not release dollars without a very clear plan from us on exactly how we're going to spend them, including they're going to examine every single subrecipient grant. So every grant we put out with these dollars, every contract we write with these dollars, CMS is going to have to approve on a line-by-line basis. So it's very high degree of oversight. And so the challenge for us is going to be to move quickly, even with that level of oversight. That's going to be part of the challenge that we face as we move forward. CMS is being very responsive to us, but that it's going to be a tremendous amount of material for them to examine and consider in this process.
Sounds miserable.
Yeah, but I even, think about how just the developed workforce, we heard last week about, the fact that we have a 30% travelers and how that is just, putting extra pressure on a lot of our providers. If we can bring that down to even the national average of 5%, maybe that will free up some of that emergency financial relief money that we spend.
That's right. Right.
So
yeah, again, we have to be careful here. We cannot supplant the state budget. So things that we already pay for routinely in our state budget, we can't use that. We can supplement, but we can't supplant.
Gotcha.
Yep.
Yeah, go ahead.
Oh, sorry. Go ahead.
Oh, hi.
I can't really see the room, so it's hard. I'm relying on Dan's voice.
This is Kylie Heiber with the State Long-Term Care Ombudsman. And I hear you saying that we can use the money to help with staff recruitment. Is it possible to use the money to help encourage the forms of medical practice ownership that we know are higher quality local ownership, nonprofit, that kind of thing? Can we use the money to help support ownership models in addition to specific individual staffing? Does that make sense?
It actually doesn't make sense, so I'm going to need you to try again.
Okay.
Sorry.
Okay. So I know we can use the money to help recruit staff, doctors and nurses and individual people to be hired by an organization. Can we use the money to help encourage ownership model, like help support local ownership, nonprofit ownership?
I don't think, I haven't asked that question that way. You mean like say local ownership of a nursing home, for example?
Yes, or medical
I don't-
practice.
I think probably not. I haven't asked that question that way. I can, just as I think about this, there's definitely, so one of the things we talked about was, and this actually somebody else brought this up in terms of hospitals, but we have a lot of infrastructure that needs to be like healthcare infrastructure that really needs to be shored up. We can only use these dollars for very minor renovations, and we cannot increase the value of a building in the renovation. So we can support, we can buy partitions, we can buy like vent covers, we can do like sort of minor modifications, but we cannot increase the value of a building, which is what makes me think we probably can't help somebody own a building either. I think that's really unlikely that CMS would support that.
Okay, thank you.
Actually, here, Dan, this is another time for me to say something else, which is, and people have lots of ideas, which I actually really appreciate, but also can't fully absorb right now. So what I've been telling people in most settings that I go to is right now, the plan is the plan. So we have our projects that have been approved by CMS, and we're moving forward on executing those pretty fast. We're trying to get as many dollars obligated by the beginning of August as we can, because on August 30th of this year, we have to provide a report to CMS about how we're doing on against the plan that we developed. And that is gonna have a big influence on how much we get awarded in year 2. Now we have another year to spend the money. So we obligate it, and then we have until September 30th of 27 to spend it. So what we need to do is sign contracts, put out grants, like or sign grants. We have to get everything ticked and tied and wrapped up that people understand who they are and how they're going to be able to spend the money. And then we have a year to spend it and administer it. So as we move into year 2 and probably even year 3, we may start to think about ways in which we want to add new specific projects under some of these initiatives, and we may have some flexibility with CMS. We're going to need to get more guidance on that. But we may move back into a more of a creative process than frankly we're in right now. Right now we're in like a heads down, get her done mode, because we really need to execute on what we've already proposed. But I put in the chat a link to our website, and there on that website there's a contact form, and so there's a way that you can email the Rural Health Transformation Program team at AHS, and so it's a shared inbox. 6 or 7 of us have access to it. And that is a great place to put new ideas. We are collecting them. We are paying attention to them. We're probably not going to be able to do much with them right now, but we are really interested in hearing people's ideas. So I don't want anyone to feel like we're not accepting ideas. We're just really focused on executing right now on the ideas that are already on the table. The other thing you can do on that website is we have a listserv where if you're and this is more relevant if you're likely to apply for the funding, but where you can sign up for notices. So it's just an email listserv. So we'll send out a notice when we've got a new RFP up or a new grant opportunity, so that people will be providers, for example, or other partners are aware that we've released an opportunity for people to apply for. At the beginning of this, we heard from a lot of anxious providers that they were going to miss their opportunity to apply, that they wouldn't see what was happening, and that they have to keep checking our website. And so we really wanted to give people some reassurance that they would hear from us when things happen, so that they could not miss an opportunity.
This is fantastic. I really appreciate your time today. And I'm glad you're there, because I have complete trust in you, having worked with you over the past 10 years, I think. And so, yeah, looking forward to see how this rolls out over the next years, and really appreciate you taking the time to kind of give us an update. So
I'm happy to. I'm sorry I was disorganized. And I appreciate your vote of confidence, Dan. You call my husband, let him know that you're happy, because I can tell you he's not. So He'd like to see a
got
little
it.
more of me, but. All right,
good.
thanks, everybody.
Good work. Thank you so much.
Take care, bye.
All right, next up, we have Mike Fisher, who's going to give us an update on the MSP program that we increased the eligibility for last year, and really thinking about how this is going to benefit a lot of older Vermonters. And Mike has been working on this forever, and we all look back now and say, wow, we should have gone a little further than we did. But here we are, and I appreciate you taking the time to come here. I sent out some information in the link to the meeting. And then, you know, I know that Vermont Legal Aid always has the ability to provide any information people need. So I'll turn it over to you. Just give us an update of what's going on and what the program is.
Great, so good to be here, Mike Fisher, healthcare advocate. Yeah, I sent an email to all members a couple weeks ago.
Yeah.
So if you have some information.
Yeah, I took a piece of that and hooked it to the bottom, so.
Yeah, so we at the Healthcare Advocates Office have been working on this project for, I don't know, maybe 8 years.
Yeah.
A long time, recognizing that there were some opportunities to use state dollars in sort of the most bang for the buck way of drawing down federal dollars. And anyway, we're really proud of the work that the legislature did in the last couple of years to expand the MSP program. The new income limits went into effect January 1st. And DEVA did a great job of moving the known populations of people, the people who were on sort of lower levels of MSP to, you know, to the appropriate level. And then secondarily moving people who were on VFARM. So all the known people into the MSP program. We think that there's about 12,000 Vermonters, an estimate of 12-ish thousand Vermonters out there who we need to find and make sure that they know about it. There are scenarios today for very low income people just above the MSP levels, you know, 202% of the federal poverty level, who are between their Part B premiums, Part D premiums, and oh my God, if they could possibly afford a Medigap plan, who are being asked to spend like 40% of their income on those things. That's even before cost sharing. So there's plenty of low-income people who we are not reaching yet. And this kind of goes a little bit to Dan's comment. Maybe we could go a little bit higher. We will continue to advocate to go further. But there is a program out there now for low-income seniors and disabled Vermonters on Medicare to assist, to help them pay their premiums, help them afford their prescription drugs, and for people up to 150% of the federal poverty level, help them afford their copays. So I actually made a couple copies of a presentation that we did in House Healthcare the other day. And I really don't have a lot more to say other than we need help getting the word out. And so when Dan said, hey, can you come by and say a few words? Here I am saying a few words.
Fantastic.
This is an incredible opportunity. You know, maybe another thing to say is there's so much bad news out there everywhere you turn, especially in healthcare. In my world is bad news, bad news, bad news. Where are we losing ground? Where is there risk of losing more ground? Where do we expect hard news to be coming? And here is a bright spot. Here is a place where the legislature really significantly improved access to care and rescued a set of Vermonters who arguably couldn't possibly afford the care.
No, this is something that you and I have been talking about, and really, it's great seeing this like start to happen. It's just a matter of getting the word out to people, that, find out if they're eligible. And I think about the Medicare, the saving, the programs, that left Vermont.
The Part C plan.
Part C plans that left Vermont, and these are coming in right at the right time. If someone was able to afford one of those, because these are really low income. And that's why it would have been good if we had seen those Part C plans leaving, we could have made the case probably to bump it up a little more, but here we are. And we'll see how it rolls out, because, in the future, this might be something in FY 27 that we look at again based on how many people just almost made it, right? So that would be an interesting number. It's like, okay, once we find out everyone who's eligible, how many people were turned away, that we might be able to capture in another increase to this. But there was a change, right? That we can't increase it past a certain amount in some federal changes.
No, I think that the recent federal changes had to do with outreach efforts, sort of how the state puts people on these programs. We were able to make this change without fear of whether the federal government would okay it.
Okay.
And just, there's two different levels of this thing. I've been speaking almost entirely on the benefit to providers, benefit to people, Vermonters side of things. But from the policy side, I just don't know of another place where you get so much federal money. So just to say it out loud, the state put $5.6 million into this benefit increase. That was the state's share. And the value to Vermonters is estimated at $67.8 million.
That's awesome.
Wow.
I know.
I often hear these conversations, sort of theoretical conversations in rooms around this building. How do we improve access to primary care, for instance? Here's how you do it.
Yeah.
It's a relatively small investment, and you get people coverage who can't afford to get the care they need. But if that $67 million, let me admit, some of it is sort of value of their prescription drug coverage. That's not exactly cash in their pockets.
Right.
But there's a key part of it, and that's the Part B premium payments. Almost $35 million. You guys put $35 million into low-income Vermonters' pockets. Not theoretically, it's real cash in their pockets that they can spend on fuel or groceries or whatever this past year. Can you think of another step forward to fight poverty in recent years?
Yeah. Appreciate all your work on this, and it's always good to get a little kudos, so thank you. All right,
So I'll come back next year and say,
Yeah.
let's go a couple more points.
I think we should, right? Yeah, you almost think that we should try to figure out how to expand it now and
DC,
set the table for FY 28 or something.
you have to hide, so we bring Quimby, the level that covers cost sharing, up to 150. Plenty of states are doing 250. DC does 300.
So some states are doing 250, others 300%.
Well, DC is maybe an animal of
Yeah.
itself, it's a little hard to compare.
But
DC.
250 is out there.
Yeah.
We wouldn't be a standalone, and we're at 150.
Yes.
So 100% increase. Right, which I think we would also see a greater participation, because there's definitely more people that have just a little bit more to be able to qualify. So, all right. Well, thank you.
And as always, if anybody knows of somebody who's having a hard time maneuvering through the complex healthcare system, please give me a call.
Yeah, perfect. All right, thank you so much. Before we go, any last announcements? Anyone wants to say anything? Next week, gonna try to put something together with an update on Age Strong. May have to push it back a couple weeks, but thank you so much to everybody. Appreciate coming today, and we'll talk. Have a great week.
Thank you.
Bye-bye.